Mike.
Who is a homemaker, came with a chief complaint of jaundice and itching for 3 months. History of presenting illness. She had a complaint of abdominal pain for past 3 years, which was predominantly present in the upper abdomen, dull aching, intermittent, no aggravating and relief factors, for which she was diagnosed as a case of pancreatitis and treated for the same. There is history of jaundice for 3 months, first observed while first observed as passage of yellow colored urine, then she noticed yellowish discoloration sclera, which was progressive. There is a history of itching present for the past 3 months, present all over the body, which is more on the extremities. There is a history of clay colored stools for past 3 months. There is history of loss of weight around 12 kgs for the past 3 months. There is history of loss of appetite. There is no history of vomiting, no history of fever, no history of melena, hematemesis, no history of back pain. There is no history of smoking or alcoholism. There is no history of blood transfusion. There is no history of any IV drug abuse. Past history: patient is a non-diabetic for past 12 years on OHA. That is, he is taking metformin for 500 mg BD. There is no history of sterilization done 29 years ago. There is no history of any previous hospitalizations. Present history: she is taking mixed diet. There is no addictive habits like smoking, alcoholism, or betel nut chewing. Sleep is normal. Family history: she is married, has 3 children. There is no history of similar complaints in the family. Summary: she is a known case of pancreatitis and pancreatitis since 3 years and diabetes mellitus for 12 years. Now came with the complaint of jaundice for past 3 months. Past 3 months with history of clay colored stools, itching, loss of weight and appetite. Mostly a case of obstetric jaundice, probably due to malignant etiology.
Why malignant etiology?
Sir, first the age of the patient. She is 57 years old. Then there is loss of weight. There is loss of appetite. Then progressive jaundice.
Associated with?
Then pancreatitis. He is already a known case of pancreatitis, which is also
In the history. To suggest malignancy. In the history itself, to suggest malignancy. Progressive jaundice associated with
clay colored obstetric jaundice features plus
severe pruritus.
pruritus. Yes.
So what is pathophysiology of pruritus?
There is deposition of bilirubin in dermis, which activates the mast cells, causing release of histamine, which causes pruritus.
Bilirubin or something else?
Bile salts. Sorry, sir. Bile salts, sir.
Biles. Okay. What is mechanism of clay colored stools?
Clay colored stool. Since there is obstetric jaundice, there is no stercobilin is formed in the stools, which gives the color of the stool.
So what happened to the enterohepatic circulation?
Enterohepatic circulation also, sir. It is not, since bilirubin is not formed in the canaliculi. There is no enterohepatic circulation, sir.
Because of biliary obstruction, what happens to the What happened to the enterohepatic circulation? It is present or absent?
Absent, sir.
Look, whether it is absent or because the biliary obstruction, what happened to the enterohepatic circulation? It is simple only. It's not complicated.
Reduce enterohepatic circulation.
So what happens? Intrahepatic stasis.
Sir,
In the bowel, what happens? Intestine.
Sir, bilirubin is not present, sir. There is present in the bowel. So there is less formation of
So bile pigments and bile salts, what happened to that?
In the bowels, it is released only, sir.
It is not recirculated. No?
Yes, sir.
So it doesn't come to the intestine. So what happens?
There will not be any color for the stools. Stercobilin will not be formed.
Okay.
So why do you say this is a case of jaundice? Why do you say it is an obstetric jaundice? why do you say it's malignant? All these, what are the points in favor of these in your history? And is there any relationship with that pancreatitis and diabetes mellitus to the onset of jaundice? You need to explain that from your history. Tell me, why do you say it's jaundice?
Sir, there is a yellowish discoloration of sclera, yellowish discoloration urine. There is a yellowish discoloration of soft palate also.
What should be the cut of bilirubin for this yellow staining?
More than 2 for sclera.
It is more than 2.5.
Speak in the mic, speak in the mic.
More than 2.5 for the sclera and more than 5 for the skin.
Right. 2.5 to 3, sir. So 2.5 to 3 you need to have for the staining of the sclera. Right. Why the sclera has less threshold for bilirubin and the skin has more threshold?
Sclera has elastin in it. Elastin has high affinity for bilirubin.
Okay, fine. Is there any other condition which can produce a yellow staining of the sclera apart from jaundice?
Keratonemia.
Yeah, keratonemia can produce jaundice. Yeah, yellow, not jaundice, or discoloration of the sclera, right? Fine. So why do you say it's obstructive jaundice? What are the points in favor to say? What are the other types of jaundice you know?
There is hemolytic jaundice.
Is that more common?
Less common.
What is the commonest type of jaundice you have?
Hepatic jaundice, sir.
Yeah, parenchymal causes of
Parenchymal
jaundice,
cause of
right?
Yes.
Fine. So medical causes of jaundice. That is more common. Then you have obstructive jaundice, and then you have hemolytic jaundice. Right. What are the points in favor to say that this is an obstructive jaundice in your presentation?
First, progressive jaundice. In hepatic jaundice, the value there is
Well,
not
medical jaundice will not be progressive, and alcoholic liver disease can have a progressive jaundice.
clay colored stools, pruritus.
Okay, fine. Clay colored stools and pruritus in favor of this thing. So as you said, sir, as for the explanation of clay colored stools and pruritus, then why do you say it's malignant?
Sir, there is associated loss of weight which is significant, 12 kgs over 3 months.
Regarding this jaundice, what is the point in favor
Progressive
to say?
jaundice.
Pardon?
Progressive jaundice.
For both obstructive jaundice also it's progressive jaundice. For malignant also it's progressive jaundice. So progressive jaundice, right? What else? What is the main feature, man? What are the two differential diagnoses you have for obstructive jaundice? Common diagnosis.
Painless and painless.
Yeah, that's what. What is the other condition which can produce obstructive jaundice?
Viral hepatitis, which is
Pardon?
cold.
Obstructive jaundice. I'm talking about obstructive jaundice. We have come to obstructive jaundice, no?
Cholangitis.
Yeah, it's cholelithiasis. Cholelithiasis versus malignancy. These are the two conditions you need to differentiate very commonly. Apart from that, you have other causes of strictures or the intraluminal causes, all that you have. But still, commonly we come across cholelithiasis or malignancy. So how do you differentiate these two? It's one is a painless jaundice, other one is a painful jaundice, right? So this is a painless progressive jaundice which you are having. This one, malignancy. That's why you are saying it's a malignancy. This patient didn't have pain, right? No. Fine. Then we have the summary.
Sir, a patient is a known case of pancreatitis for 3 months, 3 years, and non-diabetic for 12 years with complaints of jaundice for past 3 months, which with the history of clay-colored stools, itching, loss of weight and appetite, probably obstructive jaundice with malignancy.
Okay. So you have points in history to say that it's jaundice. You have points to say that it's obstructive jaundice. Or there are points in favor of being a malignant etiology, right? It's painless progressive jaundice. Okay, right. Go ahead.
On examination, the patient is general examination. On examination, patient is conscious, oriented, built normal, ill nourished, ECOG score of 1, BMI is 12.4.
So what are significant? Just tell us the positive points.
Itrix present, yellowish discoloration of palate present. Examination of abdomen after getting consent from the informed consent in velodrome with adequate exposure from nipple to mid-thigh in supine position. Inspection abdomen flat, umbilicus in midline inverted. All quadrants moves proportionally with respiration. A fullness noted over the right hypochondrium and umbilical region. Skin over the abdomen normal. Bilateral flanks free. Bilateral renal inguinal region free. Bilateral renal angle free. External genitalia normal. Left supraclavicular fossa free. Palpation, no rise of local rise of temperature, non-tender.
What do you find in the inspection?
The
There's a fullness.
Yes, sir. Fullness noted
Fullness in the epigastric region. Right hypochondrium.
right hypochondrium and
Right hypochondrium extending up to the umbilicus.
It is localized or it is extending to umbilical region?
down.
Is it localized to right hypochondrium or
Right
is it
hypochondrium slightly extended. Downwards to
downwards, sir?
From the right hypochondrium it is coming to the umbilicus. Is it?
yes, sir.
Okay. Okay, go ahead. You present. No issues.
Palpation, no local rise of temperature, non-tender. Abdomen soft. Gallbladder is palpable. Gallbladder palpable. Liver span is
No, how do you say it's a gallbladder? You tell us the features, what you have palpated. What was the shape of the fullness you noticed in the abdomen? What was the consistency of that? There's so many things to add in that.
Palpation.
yes, sir. A single soft globular swelling of
Oh, you just mentioned gallbladder is palpable. Okay, fine. You describe that. Describe the swelling.
a single soft globular swelling of size around 6.6 centimeter present in the present below the right costal margin and midclavicular line. Moves with respiration, moves side to side, and upper border is could not be made out. It is soft, non-tender.
Upper border could not be made out means it is continuous with the liver. Fine. The mass is moving with respiration. Okay. What is the mobility of the mass? Was it mobile? It's more, respiration is fine. Apart from that, is it mobile? Side to side mobility is present. Okay.
Percussion, liver span 12 centimeter, auscultation, bowel sound present. Left is other system examination, CVSC.
Was this mass tender?
It is a non-tender.
Non-tender mass. Okay. Right.
Other system examination, CVS S1, S2 here, RS bilateral airway entry present. CNS, no obvious neurological detected. Diagnosis, my patient is a case of obstructive jaundice, probably a malignant etiology due to CA head of pancreas. I would like to give a differential diagnosis of periampullary carcinoma.
So how do you differentiate between periampullary carcinoma and carcinoma head of the pancreas in history?
In periampullary carcinoma, there will be waxing and waning of jaundice.
You speak in the mic.
Periampullary carcinoma, there is a waxing and waning of jaundice, whereas in CA head of pancreas, it is progressive.
Okay. Why there is intermittent waxing and waning?
It is due to the sloughing of tumor necrosis, which relieves the obstruction, so intermittent jaundice will be waxing and waning.
So in your patient, most likely
CA head of.
Head of pancreas.
CA head of pancreas. That is
Progressive jaundice.
it's progressive.
What will be the nature of the stools in the periampullary carcinoma?
It is a silvery white stool mixed with blood. Due to melena and tumor stools mixed with blood, so it will.
So the clay colored stools mixed with that can produce a
Yeah, it's silvery white.
White.
faint appearance, right? Silvery stools.
Okay. Then we can proceed to investigate.
Ah.
Okay. Now, how are you going to evaluate and investigate this patient? Start from the basic investigations.
So first we have to do LF. First we will do ultrasound abdomen. Ultrasound abdomen to know about it as the
First hematology investigation will finish, then we'll go for
first we
radiology.
have liver function test in which hyperbilirubinemia and direct and indirect bilirubin we will see. Then prothrombin time PTINR, which will be elongated in case of obstructive jaundice. Then
PTINR is 2.2. The value has come as 2.2. What you will do?
I will give vitamin K 10 mg injection vitamin.
Tell me how much?
10 mg IM for 3 days.
Which preparation?
Menodine. Phytomenodine.
No, but why does it come as 2.2 first?
Because vitamin K is a fat soluble vitamin. Since there is no absorption of fat soluble vitamin, there will be depletion of vitamin K dependent clotting factors like 2, 7, 9, 10, which causes which is involved in the intrinsic pathway, which causes elevation of PT, prolonged PT.
Why are fat soluble vitamins not absorbed?
Since fat soluble for absorption of fat soluble vitamin, they needs bile salts. So since in obstructive jaundice, bile salts is not coming into the intestine, fat soluble vitamins are not absorbed, sir.
Start from there. When a question is asked, to start from your pathology. Your pathology is that bile salts are not coming. Just don't say fat soluble vitamins are not absorbed. There are so many reasons. Malabsorption syndrome is not absorbed. You are obstructive jaundice, no? So give the answer to the question straight away. And moreover, certain examiners, they consider ultrasonogram to be an extension of your clinical examination, and they start with ultrasonogram first to confirm the diagnosis. But as sir said, good to start with hematological investigation also, right?
Okay, now serum albumin is 2.2 grams per deciliter in the left report.
Sir,
Okay.
usually in obstructive jaundice, there will be no hypoalbuminemia. If it is in the late stage only,
No, in your left report, the serum albumin is 2.2 grams per deciliter. So what will you do for that?
It's not that albumin cannot go down. An obstructive jaundice can lead to a secondary biliary cirrhosis, and that can lead to an hypovolemia. So that is not an explanation. If sir says the albumin is 2.2, just give us the explanation what you are going to do for that, and that tell us. You cannot say it's not going to be there, right? So some examiners, they get offended, right?
So how are you going to correct that
Albumin
before planning for further
albumin
management?
infusion. Fresh frozen plasma and albumin infusion we can give.
Anything else you can give?
High protein diet.
Okay. So LFT is over. Then any PTINR is over. Any other investigation?
CA99.
Hematological.
CA99. Tumor mass.
CA99. It's elevated more than 1,000.
More than 1,000 mucin.
The
Maybe
report has
mucinous
come as
neo.
more than 1,000.
Mucinous neoplasm of pancreas.
Mucinous.
Sorry, sir.
That is
CA99.
CEA.
Sorry, I confused it. CA99.
CA99 is elevated, it is bad prognosis. More than 1,000 is bad prognosis.
Yeah, that is one of the bad prognostic factor. Okay. Any other hematology investigation you want to do, or we'll go for radiological? CBC done, LFT done, PTNR done, tumor marker done. Anything else?
Since patient is a diabetic, we have to monitor for
That is
blood
very
glucose
important.
and
Diabetic
controlled,
status has to be controlled. So, how are you going to control that?
Since he is on OHA, we have to convert it to insulin.
Insulin therapy. Okay. Any other investigation you want to do? Hematological?
renal function. Renal function.
Renal function is must.
So talk in the mic, no? Your mic is working. Your mic is working. Yeah.
Renal function test.
So what do you expect in in a patient with obstructive jaundice, there is a renal dysfunction. Why there is a renal dysfunction in a patient with obstructive jaundice?
Since bile salts are elevated, bile pigment is elevated, it is being filtered by kidney, there may be accompanied renal failure also. Serum creatinine might be elevated, sir.
It's afferent vasoconstrictor. It also decreases the renal blood flow.
So it must be corrected
Before surgery.
for planning for any further intervention.
Right, then.
First, I would like to do USG abdomen to know about the status of intrahepatic duct, CBD dilation, presence of any cholelithiasis or cholelithiasis, and
So you want
Ascites.
to use an ultrasonogram to look into CBD. What is the ideal investigation for the CBD?
MRCP.
Emma.
Is it?
Sir,
The ideal investigation for
Yes.
the CBD is a CECT. Dynamic ultrasound is the investigation choice for the ultrasonogram. Right, it's not the CT. A CECT for the
Delayed phase,
Delayed phase at 5 minutes.
slice thickness,
Axial cutoff 1 to 3 millimeter.
So what is the contrast used?
IOX.
What is the neutral contrast? What is the neutral contrast used? You need is two contrast. You need to use a neutral contrast as well as an IXOL. So water will be the neutral contrast. You have to fill the stomach with water and then you have to inject IXOL, right? Fine. So in which phase of this you can see the pancreatic parenchyma? That is more important for us.
late arterial phase.
Fine. So that is the second phase used for the parenchymal lesions. Fine. Then, okay. What else? Go ahead. So there is a CECT shows, pancreatic protocols shows that there is a mass in the head of the pancreas. Now what do you want to do next?
Metastatic workup.
no, before that you assess the resectability, no?
Resectability of tumor.
So what are the points favor resectability of the tumor and unresectability or borderline resectable?
So we have to look for whether the superior mesenteric vein, portal vein, and involvement, and superior mesenteric artery, celiac artery, and hepatic artery is involved or not. If any artery is involved, it is unresectable.
If the vein is involved,
We can
Reconstruct it.
reconstruct it.
okay. Any other findings? Ascites,
Ascites, peritoneal liver mets, and lymph node supraclavicular lymph node enlargement or rectal nodes enlargement is also a contraindication for research. Peritoneal mets.
Would you like to do anything else
Laparoscopy.
before that? Would you like to take a biopsy from it?
Endoscopic
Yeah,
ultra.
you need to add a endoscopic ultrasound, right? Endo ultrasound should be done to look for the. Why do you want to do endo ultrasound?
Resectability. Size of the tumor.
Duct
superior mesenteric vein invasion,
invasion.
mainly seen by endoscopy ultrasonography.
And lymph node, regional lymph nodes.
Unsnip process involvement,
Superior.
then anything else?
We can
Go for US guided
if it is
FNAB. If it is carcinoma head of the pancreas, if it is periampullary, we will go for side viewing
Side viewing,
duodenoscopy.
side
It's better
viewing.
than US. Okay, biopsy confirmed as adenocarcinoma. Now, resectable lesion
unresectable.
confirmed by CECT.
So any lesion in the head of the pancreas is to be malignant. Is it right? Can you get a mass in the head of the pancreas due to something else?
Non-malignant.
Insulin.
A chronic pancreatitis can
Chronic
present with a mass in the head of the pancreas. Right. So would you like to do something else to confirm your diagnosis? Not confirm? Can be more corroborative?
Yeah, hard mass with
Yeah? Someone is telling that.
CA9.
So whenever someone asks you whether it's a tumor or non-tumor, you always think of a tumor marker. If it's got a tumor marker, just do a tumor marker for that.
Yes.
Right?
CA19.
Right. So you do a CA99. That can be more corroborative for you. Right. Then.
If the
Okay, now you have made out a custom of the pancreas. It's an operable lesion. Right? What do you do? What do you do for now?
we'll prepare the patient for the surgery.
Preoperative preparation.
Preoperative preparation, adequate hydration, and vitamin K should be given. IM 10 mg for the 3 days. If needed, PT INR is not corrected, then we will go for a fresh frozen plasma transfusion. Then control of sugar.
Bilirubin is 27.
If bilirubin is more than 15 at all, we will go for ERCP and stenting.
Blood count is normal, no cholangitis.
No
Still you wanted to put a stenting or not?
In absence of cholangitis, it is
So this numerical value has no cutoff value at all. This numerical value has no relationship to your preoperative stenting. As I said, it depends only on the cholangitis, and if the patient has got some epidural shutdown or something due to the cholangitis, then you can do a preoperative stenting, which can improve the outcome. Otherwise, there is no role of a preoperative stenting. Right, fine. So this question is commonly asked for preoperative preparation of the patient. Right, fine. You don't do a preoperative stenting. Then what else? Okay, you prepare the patient for surgery. So what surgery you want to do?
pancreatic.
Tell us. What is that?
Whipple.
Whipple's procedure. You mean a pancreatic or duodenectomy? What are the structures which are removed in a pancreatic duodenectomy?
In a classical Whipple's procedure, we will remove the gastric antrum and duodenum, pancreatic head, gallbladder with Larry. Gallbladder with the common bile duct. And we will re-anastomosis with
what is the first anastomosis you will do?
pancreatic jejunal anastomosis.
Yes, next.
Next is colidoca or hepaticojejunostomy. Then
First anastomosis will be a pancreatic jejunostomy.
10 centimeter downstream we will do for colidocojejunostomy, followed by gastro.
Colidoca or hepatico?
Hepatico.
Where will transect the bile duct?
At the cystic plate bile.
In malignancy, where will transect the bile duct? Level of transection.
At the
Above the level of cystic duct
cystic
entry.
duct.
Why? Why you want to transect the bile duct above the level of cystic duct entry? Why not below the level of cystic duct entry? You want to achieve margin clearance, no?
Margin.
Because we are dealing with we want to achieve R0 resection.
R0 resection.
So that is the idea of doing bile duct transection above the level of the cystic duct entry. Then transected. So you anastomose, 2 anastomosis over. One more anastomosis is there, no? Gastrojejunostomy. Suppose if you open the abdomen, you found inoperable. There is infiltration of the supramesenteric artery and supramesenteric vein. It's infiltration of the Ansner process.
We will go for triple bypass surgery, which is colidoca or polycystojejunostomy with gastrojejunostomy and jejunojejunostomy.
Okay. Why jejunojejunostomy?
To prevent to divert
To prevent bile entering into the
bile into the stomach.
Bile reflux in stomach.
Okay. Suppose this is a case of a colidocolithiasis. What will be the presentation? Come quickly, tell me what will be the presentation. What will be the investigation you will do? How will you manage this case?
If it is a case of it is an intermittent jaundice, intermittent fever will be pain, biliary colic, intermittent colic pain.
What do you call that? Charcot striate. Right, fine. Then that will be the presentation.
Then we will do for MRCP. You have to do for the. First we will do USG and we will confirm the
stone disease.
stone is or not. If it is confirmed, then we will proceed. IHBR dilation is there, and we will proceed with the MRCP to know the anatomical orientation of the common presence of stones in the CBD and insertion.
Right, what do you do then?
Then we can do ERCP to visualize the biliary tree, followed by a removal of stone by using Dormia basket, and later in the same sitting we can do a lab cholecystectomy also. If it is not possible to remove the stone by ERCP,
Why will not be possible? What is the cutoff size of the stone which can be accessed by ERCP?
2 centimeters.
2 centimeters. Up to 1 centimeters can be removed on the ERCP by ERCP. Right? What are the other options we have?
Lithotripsy.
As a surgeon, what are the other options you have?
Yes, we failed.
lab cholecystectomy and exploration of CBD.
Lab CBD exploration with lab chole you can do, right? Then you can do open CBD exploration with the cholecystectomy you can combine, right? Okay, you open the this thing CBD. How do you close it? What are the various options you have? You just tell what you are doing in your institution, what you have done.
After CBD exploration, how we are going to complete the colorectal?
Do you do a primary suturing? Do you use a T-tube?
T-tube.
T-tube insertion.
We will put a T-tube and then close. After 10 to 14 days, we will do a cholangiogram to see for any residual disease or residual stones. If the residual stone is present, we will dilate the tract and removal of stones can be tried. If it is failed, we can do for ERCP removal.
Why are you going to have a residual stone? How do you confirm that you don't have a residual stone? How do you remove the stones in a CBD? What is the forceps you use?
Desjardins forceps again.
Right. So if there is a distal stricture, you need to dilate the ampulla. How do you do that? What does the dilator use? Pardon? Balloon dilator.
Fogati.
There's one instrument called a Beck's dilator, right? Use that to dilate the ampulla, right? So once you have done that and your feeding tube passes freely into this thing, you may not miss a residual stone. But you can have a retained stone, right? What is the retained stone? What is the difference between a retained stone and a recurrent stone?
Retained stone will be less than 2 years of cholecystectomy. It is in more than 2 years means it is a recurrent stones.
Okay. Right. So you place a T-tube, you have done a T-tube cholangiogram, the dye passes freely. Then what do? You just remove it, pull it out? T-tube cholangiogram shows the dye passes freely into the duodenum. Then what do?
Yes, sir is asking we can remove the T-tube or not? We will wait for how many weeks?
Wait for 6. We have 6 weeks.
You need to clamp the T-tube for 1 or 2 days. Look that the patient doesn't develop jaundice, and then you need to remove the T-tube. You cannot just pull it out like that. Okay? Fine.
Suppose the size of the stone is very high, 2 centimeter stone in the CBD. What do you do?
Open cold docotomy.
All that you do.
Remove the stone, then put T-tube via another incision. Close the
T2, when such a large stone is there, why? Similarly, when you do the cholecystectomy for the colorectal cyst, we don't close it with the T2.
Is there any other method of bile reaching the intestine?
Biliary drainage procedure there, sir is asking.
Biliary enteric bypass எதுவும் பண்ணுவீங்களா?
We can do for cholecystostomy.
cholecystectomy or choledochoduodenostomy.
Or choledochoduodenostomy.
So if it is a lower level, choledochoduodenostomy you can attempt.
If it is high, you have for the choledochoduodenostomy.
Suppose you wanted to do a surgery, how will you prepare the patient for surgery? Covered. Okay, that's. I think you
Suppose you have done an intraoperative injury to the CBD. Intraoperative injury to the CBD. What are the options you have? That will finish.
If you
Three mm.
Is there any stage reading?
As per the
greater than 2 centimeters from the confluence, then injury less than 2 centimeters from the confluence, then E3 at the confluence, E4 complete destruction of confluence, E5 all
suprahyla, above the hyla.
So what will
manage?
if you find the at the time of surgery, if it is less than 3 mm and it is a non-cautery, less than 50% non-cautery injury, we can do primary
Primary suture repair.
primary suture repair.
Can do. It is undilated duct. Controversial. That's a controversy. Okay.
Thank you everyone. We'll be winding up this session.
Well done. Both well done.
Thank you, sir. May I request